The topic for today's session is stroke tele-rehabilitation, and our presenters today are Angela Lybyk, Stroke Tele-rehabilitation Project Officer at Barwan Health, and Andrew Rank, Physiotherapist at Colac Area Health. Thanks, Angela. Over to you.
Thank you all for taking the time to participate in today's webinar. So we'll get started. The Barwan Southwest region has the largest number of stroke rehab inpatient separations and the largest number of stroke client service events in Victoria. The region itself spans from the South Australian border to the tip of the Queenscliff Heads. It is this incidence of stroke and geographic spread that makes the region an excellent candidate for the establishment and evaluation of the feasibility and usefulness of stroke telerehabilitation. So between February the 24th and June the 30th, 2014, Barwan Health and Western District Health Service partnered in a pilot project, or Phase 1, to assess the feasibility of a stroke tele-rehab service for inpatients. The aim of the project was to establish and pilot a regional stroke tele-rehab model to build staff clinical skills and capability to confidently and competently provide stroke rehab and enable stroke survivors to receive the care they need closer to home. So Phase 1 key achievements included identification and engagement of key stakeholders across Barwan Health and Western District Health Service, development of a memorandum of understanding between all participating sites, completion of gap analysis which focused on identification of clinical knowledge and skills gaps according to the skills and abilities identified in the stroke-specific education framework, as well as skills and knowledge in the use of telehealth. The survey results identified key needs with relation to stroke-specific and telehealth education. Development of pilot tele-rehabilitation service model and trial with one stroke survivor over 2 consultations. So the pilot achieved favourable outcomes in identifying the need for further telehealth education and governance structures to support the sustainability of a telehealth model. And in September 2014, Barwan Health, Western District Health Service and Colac Area Health partnered to apply for an additional round of funding through the VSCN for the provision of the tele-rehabilitation service to improve the capacity and capability of rehabilitation teams to provide evidence-based assessment and treatment for stroke survivors in the Barwan Southwest region. This funding application was successful and Phase 2 commenced in March 2015. So from March 2015 to October 2015, Barwan Health, in partnership with Hamilton and Colac, piloted the stroke tele-rehab model. Okay, sorry about that. So Barwan Health were the hub site and Colac Area Health and Western District Health Service were the 2 spoke sites. After an 8-month hiatus between Phases 1 and 2, it was reinvigorated. The use of video technology allowed specialist regional allied health staff provide assistance, advice and education to rural clinicians to assist in the provision of stroke rehabilitation for stroke survivors. The project deliverables included the project commencement, so we recruited to a project officer position. We engaged with other regional providers and expanded the scope of service delivery to include other services, conducted on average fortnightly clinical consultations using the tele-rehabilitation model as per patient need. We developed an education plan based on gap analysis findings to increase workforce capability in the area of stroke rehab, monthly education sessions using video conferencing facilities to address identified gaps. We reviewed funding models and opportunities to embed service model into practice to ensure sustainability beyond project funding. We evaluated effectiveness of service model through collation of patient and clinician experience surveys, as well as repeating the gap analysis in Phase 1. We evaluated the effectiveness of the service model through collation of, we've just covered that. We presented results of project at relevance conferences and completed report and recommendations. So the key stakeholders involved this year were project officer, allied health clinicians, nursing staff, rehabilitation physicians, operational managers, telehealth program manager and project officer, and clinical and admin support staff. Without their engagement, involvement and willingness to contribute to embedding stroke tele-rehab into business as usual practice, the outcomes achieved in this project would not have been possible. So the project aim and objectives in Phase 2 was to extend the stroke tele-rehab project for a further 32 weeks as per the funding to facilitate increased capacity and capability for the provision of evidence-based stroke community rehabilitation in the Barwan Southwest region. The objectives included to further develop, refine and evaluate the pilot model for tele-rehab service to ensure sustainability beyond the life of the project funding, to extend the current pilot to include Colac area health and community rehab, and to embed a flexible model of stroke tele-rehab into usual practice at all participating sites, to facilitate the development of therapist-to-therapist relationships across different sites within the Barwan Southwest region to enable timely mentoring and support and access to specialist clinical skills, to develop and implement clear and transparent processes that provide a governance structure for the tele-rehab model of care, including clear and documented service procedures and guidelines. And finally, to ensure participating sites are supported to participate in benchmarking activities, for example, the National Stroke Foundation audit in the future. So, to form the basis or the foundation of the project, we used a people, processes and technology approach to embed the stroke tele-rehab into standard business practice at all sites, with an emphasis on how can we enhance the stroke survivors' experience and outcomes through the provision of tele-rehab. So key project activities. In order to effectively meet the stated objectives within the funding submission, Phase 2 of the project consisted of 4 key activities. These were direct education to address the knowledge gaps identified during Phase 1, patient consultations, specific patient advice sessions with an integrated educative and clinical supervisory component, and the development of a stroke tele-rehab toolkit. So the project evaluation was conducted in line with the primary aim of the project to establish a sustainable regional tele-rehabilitation service that increased the equity of access to best practice stroke rehab with the key interventions of direct patient contact, clinical supervision and staff education sessions. Thus, the primary outcome measures related to the stroke survivor's experience of the tele-rehab service, changes in clinician knowledge and confidence, and increased capacity and capability for the provision of evidence-based stroke community rehab in the Barwan Southwest region. Patient outcomes were evaluated through a series of stroke survivor case studies, clinician and consumer experience and self-efficacy surveys. In addition, details of stroke survivor consultations were recorded, including the number, type and duration of consultations. The framework for the service delivery. So this was basically the stroke tele-rehab toolkit, and again was established to provide the framework for service delivery and some of the existing use some of the existing telehealth templates and resources developed by the Part 1 Southwest Region Telehealth Program. These are represented in the figure in blue, and hopefully this framework for service delivery may assist other health services in adopting a similar model. So the stroke tele-rehab session, so during or between May and October of 2015, 23 consultation sessions, which were inclusive of patient education and patient advice sessions, were conducted using the tele-rehab model. These sessions were a combination of physiotherapy, occupational therapy and multidisciplinary reviews. So the stroke survivor benefits and outcomes. Benefits of these consultations included the facilitation of the stroke survivors' rehabilitation goals post-discharge from the McKellar Centre, which is at Barwan Health, reducing the stroke survivors' anxieties regarding their discharge. It saved a considerable amount of travel time, ability to incorporate telehealth into the discharge planning process and regular multidisciplinary team meetings. It improves clinician relationships and facilitation of a smooth transition between services for the stroke survivor. I'll hand over to Andrew now, who will speak to you a little bit about one of our main case studies provided in our final report.
Thank you, Ange. So like Ange said, my name's Andrew. I'm a Grade 1 physio down at Colac Area Health, and I've been working down here since March of last year. What I'm going to do is just present the case study of a stroke survivor who I worked with over my first year as a physio here, and I was supported in managing this client through Telehealth by Natasha Selenitsch, who is the clinical neurology lead physio at Colac Centre, so I'd just like to thank her for her support. So I'll just run through a bit of the background of his case, and then I'll discuss both of our experiences with stroke tele-rehabilitation, and I'll also go through the process that we use to set up consultations, the equipment and the staff involved, and also the documentation policy. So this is a 53-year-old man, lives at home with his 2 kids, previously worked at a local school as a groundskeeper and also on a local farm. Really loves getting outdoors, especially going fishing and hunting with his kids, and he also works to help support his mother on her small local farm. So unfortunately, in November of 2014, this man was at work and noticed his right side wasn't moving very well, and his speech had become quite slurred, and eventually he was taken to University Hospital Geelong and diagnosed with a left MCA infarct. He now had no functional use of his right arm, right foot drop, and other problems with spasticity and strength on that side, some impaired balance and gait, and also expressive dysphagia. After 2 months of inpatient rehab at Colac Centre in Geelong, he was discharged back home to Colac for ongoing community rehab. So his community therapy included twice weekly physio and OT, as well as weekly speech. And after initial assessment with the team, he identified his main goals as being able to walk faster and further, get back to work, wanted to be able to help out with jobs around the house, and did want to work on his speech. But his main focus and his main goals were on getting back the use of his right arm and also getting back to driving. So when this man was discharged back to Colac, Natasha contacted me and suggested that he'd be appropriate for telehealth. And then between June and October of last year, we conducted 5 telehealth sessions. So one of these was an over-the-phone advice session, but the other 4 were all video consultations with myself and the stroke survivor present in Colac, and Natasha present at Colac Centre, just watching us via video link. So this slide just presents a summary of the focus and also the outcomes of the sessions. So through the video, Natasha could watch my sessions with the client and give me some feedback on different neurological assessment skills and handling, and also give me some advice on different treatment ideas and techniques. Other sessions were more discussions around ways to increase community access and social involvement, and these also involved stroke survivors' family, and also one of them had our occupational therapist here at Colac, and Sarah, an OT from Barwan Health as well. So I think as a result of these sessions, this man was able to receive the specialist input and just the level of care that he would have got if he was being treated in a more major network. And obviously it also gave me the opportunity to receive some specialist clinical supervision and develop my own neurophysio skills. So I just wanted to have a bit of a talk about the way that we set up when we're having the sessions and also the equipment we used. I think initially at the start of the project, I was probably just a little bit concerned that it'd be really time consuming, getting everything organised, or we might have some technology breakdowns, or it might be really difficult interacting with a clinician at the other end, and that it might be a bit more hassle than it was worth. But I think in the end, I was really surprised at how easy it was and how well it worked and just how beneficial it was. So at my end, all we had was myself, the stroke survivor, and an allied health assistant to help with the filming. And the only equipment we needed was just a laptop and a USB webcam. And then we just used Polycom or just a conferencing software to call Natasha at Colac Centre. And then using that setup, she could watch what we were doing, so she could observe assessment or gait or any other functional tasks. She could interact with the client, ask questions, give me instructions or feedback on different techniques. So a couple of little photos. So this is just, you can see the laptop there set up with the webcam. Natasha's just watching on the screen and giving some feedback on, might have been some scapular facilitation stuff. And then on the left, I think we just done some gait part practice, looking at his walking, and then we're doing some reassessment, and Natasha was having a look at that. And then on the right, we've got one of our lovely allied health assistants, Julie, just running through the client's upper limb OT program, and Natasha's just giving some feedback on that as well. So if we go back a little bit and look at the process of setting up a consultation, so the first step was identifying when a telehealth consultation would be useful. So for this man, after he was actually at Colac Centre for his inpatient rehab, so he worked with Natasha, and on discharge she gave me a call and we agreed it'd be a good idea for me to have some support. In other situations, a referral could just be faxed or emailed through the Barwan Health, where it would be triaged as normal and then acted on. Obviously, before a referral was sent through, we'd discuss telehealth with the consumer, so we'd explain what telehealth was, what the potential benefits and risks were, and then the consumer was able to provide informed consent. Once the referral had been accepted, the clinicians would set up a time for a consult, and then after the session was finished, for the purposes of the project, the consumer and the staff involved would complete a survey just about their experience, and I think Ange talks through the results of those surveys a bit later on. And then obviously if there was to be any follow-up, then this would be organised. In terms of documentation, so obviously the same process of documenting a consumer consultation applies to telehealth as it does with any other consultation. So there was a form developed called the Stroke Consultation Summary, which was signed off on by both clinicians and then filed in the medical record of both sites. And then a progress note was also entered in the medical record of the home site. And I think Barwan Health is in the process of developing that form into an e-form so they can upload it onto their digital medical record. And just included in the documentation was obviously who was present, what happened, and then also the follow-up and the plan. So from the perspective of the stroke survivor, the main benefit that he identified was reduced travel time. So if he'd wanted to access neurological specialist physio, then he would have needed to drive down to Geelong. And obviously that saved him some time there just being able to come in to Colac, which he's local to. He also recognised that he likely achieved some of his goals a bit earlier and also had an improved level of care as a result of telehealth. The main or the only really challenge that he identified was communicating with the therapist because he just found it a bit difficult to hear sometimes, but it was easy just for me to listen and then relay back what was going on. This slide's just having a look at the estimated cost savings for the stroke survivor. So by not having to travel to Geelong for those sessions, he's not travelled a distance of 686 kilometres. And if you look at a small vehicle's running cost, that equates to about $417. So from my perspective as a junior physio, especially in a small rural health service, this experience with telehealth was really invaluable. So by having access to specialist clinical supervision, I've obviously gained an improved ability to conduct my own stroke-specific assessment, but also develop treatment skills which can be used with other stroke clients. I think importantly as well, I've been able to develop some relationships with clinicians from other sites, and that's already created opportunities for further discussion and mentoring as well. And those relationships have actually already been key in a couple of acute stroke presentations we've had at Colac, where I've been able to get in touch with Natasha or Dr. Bennett, who is the rehab physician involved in the project, to get some advice. I think overall, just having access to Natasha gave me confidence that from a physio standpoint, we were just holistically managing this client's rehab and we're meeting his needs, hopefully in a way that was in line with best evidence. From the perspective of Colac Area Health as an organisation, there's obviously been a lot of benefits as well. So there's been opportunities for stroke-specific PD, like I already touched on, just good working relationships between clinicians across sites, and consultation opportunities for both acute and subacute stroke presentations at Colac Area Health. And we've already started implementing some of those into our normal care. So if a client's being discharged back from Macalla Centre to here, and they are going to be a bit of a tricky one, then we've had a couple of sessions where we've had our team on one end of the video link and they've had the client or the patient and their team there, and we've been able to do a bit of a handover, and the patients had the opportunity to meet their new rehab team, which they've always really enjoyed as well. So I might hand over back to Ange again.
Thanks, Andrew. So Natasha provided us with a bit of an overview on her experience as the senior clinician at the hub site. So her feedback was the rural health services are often better equipped with telehealth technologies and more familiar with how it functions. Supervising over video conferencing is very different to face-to-face, particularly with the stroke survivor present. Senior clinicians at the hub site had to develop new skills in how they analysed movement and how hands-on therapy was facilitated. So Andrew touched on that when we saw some of the pictures on the patient or stroke survivor's gait aid and assessing that. Stronger relationships between all sites were developed, and discharging complex patients to areas where there isn't specialised neurological skills comes with concerns that they may not achieve their optimum outcome, and this experience helped demonstrate ways to mitigate this. So telehealth staff experience and self-efficacy survey, measuring the impact of telehealth as an intervention on clinical or clinician self-efficacy was achieved using questionnaires, and these were conducted both pre and post the telehealth consultation with spoke site clinicians. The clinicians reported overall an increase in confidence in all areas of the assessment, treatment, discharge planning and aftercare of the stroke survivor following the tele-rehab session. Likewise, clinicians testified that their contribution to the tele-rehab consultations was valued by their colleagues and that they would continue to use it as part of usual care or business as usual practice. The telehealth staff experience survey results. So this graph primarily highlights three significant themes. Firstly, the majority of clinicians surveyed agreed that there is value in using tele-rehabilitation. 2, the majority of clinicians surveyed believed that the stroke survivor benefited from the telehealth consultation. And 3, the majority of clinicians surveyed are keen to continue using telehealth in the future. So great results were received overall. Telehealth education. So clinicians benefited from further stroke-specific telehealth education with significant improvements in assessment of the stroke survivor's motivation and understanding of the telehealth principles and guidelines and the appropriate selection of stroke survivors for telehealth consultations. So this graph basically represents that over 82% of clinicians were either extremely satisfied or moderately satisfied with the telehealth education received. So we were able to enlist the services of our Barwan Southwest Region Program Manager, Rebecca Eastgate, and Alice King to be able to conduct some of that telehealth education at all the sites. So they did face-to-face education, which was really effective. It was a 4-hour session across all the hub and the spoke sites. So sustainability, our stroke tele-rehabilitation model supports best care for stroke survivors in the Barwan Southwest region and facilitated ongoing clinical capacity building. Phase 2 demonstrated that there are various points in the stroke survivor's recovery journey where telehealth can be used to facilitate knowledge sharing, clinical handover and better clinical outcomes for the stroke survivor. And within the current funding arrangements, sustainability of the stroke tele-rehab model will be challenging for all participating sites. Long-term utilisation would be best supported through adjusted funding with associate targets to support the adoption of this model. The usual care using the tele-rehab model during phase 2 has been beneficial for both the discharge and the transition planning with care of the stroke survivor. This is able to be integrated into usual care and has the potential to be rolled out into other streams of care. So we're looking at the orthopaedic stream in particular because we've got quite a high number of patients that are currently from Colac that are in IRC at McKellar Centre at the moment. So we think that we're going to target orthopaedics as our next stream. So this model can prevent the inappropriate transfer for rehabilitation that have the potential to isolate stroke survivors from their community and reduce the burden on their carers from travelling or taking time off work to attend their outpatient appointments. Clinical supervision. So to enable the clinical supervision and education through this model, time needs to be dedicated at all participating sites. In collaboration with Barwan Health, Colac Area Health are keen to develop a regional telehealth supervisory model with specialist clinicians if additional resources are provided. This type of supervisory support would be beneficial for new graduate staff as the caseload at Colac Area Health is generalist in nature. Likewise, it would negate the need for clinicians to travel to Geelong to access protected supervision time. So some of the reported outcomes, the proposed objectives regarding consultations with stroke survivors and reporting was challenging, given changes in the committee membership and engagement of a new regional partner, as well as the limited stroke survivor numbers we had in the region at the time. Stroke survivor reported outcomes were therefore reported through those case studies, stroke survivor and clinician questionnaires, clinician-to-clinician patient advice sessions and consultations. Clinicians also conducted pre-discharge telehealth consultations involving the receiving clinicians and the stroke survivor to discuss their goals and outcomes. This enhanced the stroke survivor and clinician engagement across all health services and answered any questions that arose and improved the discharge planning process overall. So some of the project challenges faced during the time frame in 2015 included, so obviously phase 2 of the project commenced in March 2015 after an 8-month hiatus, which did affect the momentum. The knowledge gaps in stroke rehabilitation were different at each health service, which required process mapping and staff surveys to ascertain levels of stroke knowledge and also confidence developed using the stroke-specific education framework guidelines in comparison to phase 1 in order to formulate an education plan. And there was insufficient access to fit for purpose video conferencing technologies at the McKellar Centre. Some of the recommendations after the project end relate predominantly to the framework for delivery of this type of service. They provide a guide to the features of the successful tele-rehab session for other organisations considering the implementation of similar models. So advocate for funding streams is very important that support participation in telehealth consultations for allied health and nursing staff. Integrating the tele-rehab model into usual care to help plan for complex discharges for both the discharging service and the service continuing with the care of the stroke survivor. This model also has the potential to be rolled out into other streams of care, which Andrew and I have both previously mentioned. And consideration should be given to following up on anecdotal evidence from clinicians reporting enhanced confidence and skills through a more specific evaluation of the effect of video conferencing access to learning opportunities such as in services. The stroke tele-rehab project outcomes. Some of the key outcomes included that tele-rehab supported best practice for stroke survivors in the Barwan Southwest region and facilitated ongoing clinical capacity building, knowledge sharing, clinical handover, discharge planning and better clinical outcomes. Integrating this model into usual care or business as usual practice can help plan for complex discharges for all participating sites. The model also validated the need for clinical supervision and supports from a rehab level 4 hub site and has the potential to be rolled out into other streams of care. Long-term utilisation would be best supported through adjusted funding with associated targets that support the adoption of the model. So some of the project learnings and the final report since the project concluded on the 30th of October have been presented to the Victorian Stroke Clinical Network subacute and leadership groups with an updated report to be submitted in 12 months' time. The Barwan Region Stroke Meeting, the internal leadership committees and executive teams at Barwan Health, Colac Area Health and Western District Health Service, and also presented just last week at the Barwan Southwest Region Telehealth Stakeholders Committee. And a poster will also be showcased as a quality improvement innovation at the Barwan Southwestern and Grampians Allied Health Conference in April of this year. So business as usual practice. The impetus to embed stroke tele-rehab into business as usual practice continues with support provided by the Barwan Southwest Region Telehealth Program, Allied Health in Services and through continuing clinical supervision provided by the hub site. This model has been significantly effective in discharge planning for complex cases with a view to entrenching telehealth into weekly multidisciplinary team meetings where possible. So 4 tele-rehab sessions have been conducted post-project between the hub and spoke sites, which is great. And as I previously mentioned, it is still very difficult given the low inpatient stroke survivor numbers at all the participating sites. So just as we almost conclude our presentation today, Barwan Health, Colac Area Health and Western District Health Service would like to acknowledge the Victorian Stroke Clinical Network for the provision and funding for this project and say thank you for their ongoing support to us and as the hub site at Barwan Health, and also to Colac Area Health and Western District Health Service. So we'll conclude today's sessions or presentation with any questions you may have.
Thanks, Angela and Andrew, for that excellent presentation. I might get the ball rolling with a question. My sense is that as far as Colac Area Health is concerned, that most stroke presentations there would have their acute phase attended to at the stroke unit at Geelong University Hospital. Then they would normally go and have their rehab phase at Mackellar Centre as described. So is there a sense that that's still likely to occur ongoing, and that one of the benefits or perceived benefits would be that the time that the stroke survivor would normally spend at Mackellar can be reduced due to the upskilling or the transfer of expertise across the Colac Area Health, for example?
Yeah, I think that would definitely still be the normal course. I think when I was talking about the acute strokes that we'd seen before, I think in those instances they were older people from aged care. So I was just having a chat to Natasha about maybe if they did have the potential for rehab or something like that. So it'd definitely be like from an acute presentation better off if they were managed in Geelong. And I suppose the benefits of the upskilling here, but I think it's hard to know if it would reduce the discharge or the length of stay in Mackellar Centre. But we've definitely had instances now when we've done handovers with clients that have had strokes that they've reported that they've had some reduced anxieties about going home, and that's what the clinicians have said as well, is that they've felt more comfortable with discharge, knowing that they've had the opportunity to speak to the clinicians that are going to receive the care, and that the clients are comfortable with that, and that there is a really good handover process. And I think just from my own experience with the 2 or 3, there's a lot better than just reading a handover referral. If that answers your question.
Yeah, thanks, Andrew. You can see there's a few there typed in now, beginning with Nicole T, if you would care to answer that.
Yep, so the VSN grant did cover IT hardware, Nicole. What we had to do here at Mackellar especially was to purchase 3 additional Surface Pros. So we had the tablets available to the allied health clinicians to use, whether it was in the gym or the family meeting room or whether it was in their consultation areas. So we did need to purchase additional video conferencing technologies to be able to support the project in the best way possible.
And then Aubrey Wodonga's asked, did the stroke survivors access single disciplines or multidisciplines? So from our end, we worked with physio and OT was involved as well. And do you want to touch on what other disciplines were involved?
So we had speech therapy involved, our rehabilitation physicians, and also our nursing staff from the stroke unit at the inpatient rehab centre. So that was our central wing at that point, which is now moved over to North Wing. So it was very much a multidisciplinary team project, but of course it had quite more emphasis on physiotherapy and occupational therapy at the time as per the patient's needs. And just to answer Nicole's question again, we used Polycom in the first instance to conduct our steering committee meetings, and then we moved over to Health Direct software for the patient consultations.
There's a question there from Peninsula Health, Angela. Are you considering looking into the feasibility of telehealth with patients without having a clinician physically present with the patient at all, or keeping the telehealth model as a means of interclinician consultation across sites?
I think Andrew's probably the best one to answer that. Are you?
I think at the moment we're mainly looking at having with the clinician present. I think given that it's been stroke specific and most of the clients we've had have been pretty hands-on or heavy or not high functioning, it's been more appropriate to have the clinician there. But I think that's definitely something that could be used in the future. I don't know that at Colac we're looking at doing that with our own clients yet. And I'm not really sure from the Barwan end. I know, was Michael looking into, Dr. Bennett looking into doing that with any of his clients, Ange?
No, not to my knowledge, no.
So at the moment, still mainly looking at with the clinician present.
Melanie asks, have you looked into the financial feasibility for the two sites for both staff equipment availability? And she says, I could see this being a barrier for the large tertiary hospital that she's working at.
Yeah. Okay. So at the moment, we're still keeping the project sustainable without that additional funding. So in terms of financial feasibility, yes, we are looking at providing that additional EFT, and that's at the moment sitting. This is in consideration with the acting Allied Health Director. So we don't have any more funding from a VSCM perspective, but we are working with the resources that we have and the staffing that we have to keep the model sustainable. So we didn't have additional EFT provided to us, but the grant that was received covered the backfill that was required for the specific disciplines involved in the project at the time.
And Stephen B. from Western District Health Service asks, where do you envisage the responsibility lies for ongoing use and application of the stroke telehealth service, given the project is now finished?
I think it's probably for both Andrew and I, but probably the responsibility lies for the ongoing use and application for the service would be within the Allied Health stream. So again, that would probably sit with the Allied Health Director, and to try and embed this telehealth into the position descriptions and work them up from that perspective. But again, that's still to be discussed.
And I think from a more clinical level, I think it's up to the clinician. So like we've said, we've already embedded into our usual care that process of that telehealth handover, which has been really beneficial. I think that the clinical supervision model's completely different again, and obviously that's going to take more resources. But in terms of just the handover, that's something we've been able to do really easily just with the equipment we've got, and we've just turned that into a process. So when someone's being discharged here, we organise a time for a handover and we do it, and it doesn't take any more time than, you know, your normal rehab meeting or anything like that.
Thanks, Andrew. Thanks, Angela. No more questions coming through the chat facility at the moment, so it sounds like we may have covered all the questions at this point. But if there's anyone out there a little bit bashful and still has a question, by all means, you can forward them through to me and I can pass them on to Angela and Andrew for you to have ongoing discussion. Although having said that now, Southwest Healthcare mentioned, would you consider expanding the project to other sites, for example, Warrnambool?
Yes, absolutely. Would that be within the stroke stream?
I imagine that's what they're talking about. Our inpatient rehab here, probably a lot like most regional centres, covers ortho and has GEM as well as stroke, neuro and other things. So
yes,
I think that's, yeah.
Yes, absolutely. We would consider expanding the project to other sites, for sure.
Okay.
And you can pass my details on to Southwest. Be happy to have an offline chat, absolutely.
Okay, great. All right. Well, Thanks very much again, Angela and Andrew, for having a great project and running it through, as well as presenting on it today. Much appreciated. So thank you again, and if anyone is interested in re-looking at this session, try accessing it via eStroke or the soon-to-be launched Inform Me, and I'd appreciate it if anyone can forward their attendance lists back to me after the session. So thanks very much, everyone, for dialing in, and thanks again, Angela and Andrew.
Thanks, Pat. Thanks, everyone.
Thank you, everyone.